Welcome to the Clinical Athlete Journal Club number 17. My name is Quinn Hennick. I'm a proud clinical athlete provider. And as always, I am joined by Kevin McNamara, a physical therapist currently completing a residency at Johns Hopkins. If obviously we're all aware of the current crisis, and if you've seen any of the day-to-day data that's coming out, a lot of it comes from Johns Hopkins. And that's where Kevin is right now doing his PT residency. And he's a longtime Clinical Athlete Forum member and the one responsible for bringing the Journal Club to life. So thanks for being on as always, Kevin.
Of course, Quinn. Always happy to be here. Looking forward to it.
Yeah, this will be a fun one. And then I think you're going to be the point man on a lot of this conversation, because I think you're getting a lot more of this on your end as far as what we're going to actually talk about. But if anybody is interested in the impetus of this journal club and the motto that we have, we kind of modeled it after a smart guy named Benjamin Franklin, who way back in the day started a weekly club that was called the Junto Club. And it was a quote unquote mutual improvement club, but it was basically just a room of smart people discussing topics and issues of the day, kind of like what we're doing here. But they had an important policy, and that policy was that all discussions would be conducted in the sincere spirit of inquiry after truth, without fondness of dispute or desire of victory. And so that's become our clinical athlete motto. These meetings are conducted in the sincere spirit of inquiry after truth, without fondness of dispute or desire of victory. Doesn't mean there's not disagreement and good, strong discussion. It just means that we're not in it to win it. We're not looking to come out as a victor of the discussion. We're all on the same team here, and we're just trying to be less wrong. So the topic of today's meeting is a critical review of the HOP tests. And I've made a few poll questions. I'm going to launch that just to get a feel for the room. So there's 3 questions that should be popping up in front of you here. The first question is, who are you? Clinician, student clinician, coach trainer, or student coach trainer? Question number 2, have you rehabbed or trained an athlete with a past ACL reconstruction? And question 3, for the clinicians, do you use HOP testing as part of return to sport testing for ACLR? And if you're a strength and conditioning coach and you get athletes who have prior history, and you can take them through HOP tests too. So, feel free to answer that question as well. So it looks like the majority of the room are clinicians or student clinicians, about 10% coaches, trainers. And almost 90% have rehabbed or trained an athlete with a past ACL reconstruction. That doesn't surprise me. And then the majority of you, 85%, use HOP testing as part of your return to sport protocol. So probably a relevant paper for you guys. So this is good. And I'll show you, let's see, in that poll here, so you can see those results should pop up. So the name of this paper was, "Is it time we better understood the tests we are using for return to sport decision-making following ACL reconstruction? A critical review of the HOP tests." And this paper, the format of the paper was similar to a format that a paper that we looked at a few meetings ago on stretching, where that paper was only one author, James Nuzzo. This paper has 3 authors, but it's a kind of a review, but it's not a systematic review. It's not a meta-analysis. It's not a study in and of itself. They're not pooling any data or anything like that. It's kind of expert opinion on a current topic, which, take that for what it's worth. We also had a paper, the last meeting, on strength and power training and rehab. That was a similar format, kind of expert review. I like these papers because it puts things into context. The practicality is there. It's more of a kind of a discussion format that can get you thinking. Keep in mind that it's based on expert opinion. So the biases of the authors are going to come out with that. Their interpretation of the literature is going to be what is in the paper. So you just kind of take that for what it's worth. But I'll just do a quick overview, and I'll throw it to you, Kevin, and see what you thought about it, and then we'll just get the discussion going. So they started with kind of a history of where HOP testing came from, starting in the 80s and 90s. Clinicians looking for a practical, low-cost way to assess function. And then they kind of got into the literature of looking into reliability of the hop test. Like, are these repeatable tests? And in general, they are. We'll dig into some of the nuance there. And they talk about the relationship of hop testing outcomes compared to strength outcomes. Is there a relationship as somebody improves in hop testing? Are they also concurrently improving in their strength values and also in their subjective reports of their function? And then they get into some of the nitty gritty of which tests are a little bit more sensitive to change over time. Do we need all 4 tests? And when I say 4 tests, there are a lot of hop tests. The first half of this paper and kind of most of this paper, the first half of it and kind of the entirety of the paper is based on 4 common hop tests. The single leg hop for distance, the single leg triple hop, the single leg crossover hop, and the single leg 6-meter timed hop. So those are the 4 tests. You can look at figure 2 if you want to reference those. So those are the 4 main hop tests that they're kind of talking about. And then the rest of the conversation branches off of those. But then they asked the question of, do we need all 4 of these hop tests? Are some of these tests measuring the same thing? And so are you just measuring redundancy at that point? From there, they talk about other tests. So all 4 of those hop tests that I just listed are horizontal tests. So they're jumping forwards. But what about vertical jumps? What about lateral jumps? What about jumps with a rotational element? So they kind of dig into some of those and some of the literature, which is a little bit more sparse on a lot of those tests. And then they get into some interesting conversations, which I think I'm interested in towards the end of the paper, talking about the issues of comparing the involved side to the contralateral side. Is that enough? Is the contralateral side a good reference? And we'll talk about why and why not. And then also the idea of movement quality, being able to pass the hop tests, but what strategies are you using? And are those strategies going to be viable in a chaotic environment on the field? So just because you pass the test, does that mean that you're truly ready? Or does that mean that system, the system of the knee, is ready to withstand forces, repeated forces? And we'll dig into all that stuff. But so that was an overview of the paper. I liked the paper. I like summaries of certain topics like this, because what it allows you to do is to dig into references. So this is one of those papers that I'll use as a cross reference. So every time that I want to think about, like, ask a question about hop testing, I'll probably dig into this paper, look for the references for that particular question, and then dig into those references if I want some of the hard data. So you can use papers like this for that. But Kevin, what was your impression of this piece?
Yeah, I mean, I share a similar feelings just in regards to the general format of papers like this. I think especially for something like a journal club, it's great because it really fosters discussion. You don't get so bogged down into some of the details or the nuances of a specific study or a cohort. And it really allows maybe a little bit more practicality and a little bit more clinical implications for broader questions. But I really like this paper because I think it even sort of builds off of, the last, was it a couple clubs ago, where we were talking about more of like a dynamical systems approach to kind of analyzing movement in sport specific. And I think it really addresses this sort of issue or concept that we need to remember that asymmetries are going to be task and quality specific. So I think coming into this paper with the idea or the question in mind that we shouldn't necessarily expect to see the same between limb deficits or differences across multiple tests is really important when we start to talk about intervening or addressing some of those deficits, because we need to have something that is sensitive enough to identify whether a deficit is there, but also specific enough to guide us in some of the applications. So I think they bring up a lot of great points in getting into some of those details on what is this test measuring, what is it telling us, how can we use that to guide decision making. So I really enjoyed this paper for those reasons.
The sensitivity and specificity conversation is an interesting one, and I think it's important with these things, because if we're looking for a sensitive test, we're looking for a test that's going to pull out all of the true positives. If we have 100 people, we want to test that of those 100 people, for those who have the thing, we want a test that's going to identify all of those people, all of the true positives. So, beginning screening, that's why we want a sensitive test. We want to identify all those people that we want to work on and that we want to intervene on. And then as we're looking to discharge somebody, and as we're looking to see if somebody's ready, we want a test that then is going to identify all of the true negatives. Of those 100 people, of those 100 people, those who are ready, those who no longer have a knee that's affected, the true negatives. We want a test that's going to identify all of those people to say, okay, you passed this test, you're ready. And they really highlight some of the limitations with individual hop tests, some being sensitive, some being specific, some being, and kind of a myriad of the two. And if we're using, hop tests as discharge criteria, but yet we have hop tests that are not specific, we might be, like they mentioned, holding somebody back because they didn't pass the hop test. And in turn, a test that's not sensitive enough to pick up on a deficit, can have its own problems on the front end as well. Because athletes can figure out a way to pass it, and so we'll talk about that as well. But I thought that was an interesting point. The sensitivity and specificity can flip people's brains upside down, and it does for me as well. But it's important to think about that. What is the test providing you at different time points of your plan of care? But Kevin, do you guys use, for like your general battery of hop testing, do you use all 4 of the basic ones that they laid out?
This is something that I've actually kind of got the ball rolling with in terms of changing this a little bit, based off of this paper and some others in particular. So we actually recently started to move away from using kind of like the standard University of Delaware, all 4 tests. And it actually started playing around with like a single leg vertical jump, and then a depth hop as well, in addition to the single hop for distance and the triple hop for distance. So that's relatively new prior to, I think at the very least, I think if we're performing the baseline battery of looking for, 90% quad index, 90% hamstring index, and performing those 4 tests is a good place to start. But we have kind of shifted away from utilizing strictly these 4.
So I don't use, so I use a drop jump and a depth drop. I use those as separate constructs. So I use for me, a drop jump is we're going off of a 30 centimeter height, or we couldn't go lower at first, but it's reduced, it's minimizing contact time. And then I use a depth jump for maximum height. Now, in an ideal world, we want minimal contact time, maximal height, but I separate those 2 constructs into those particular tests, but that's vertical, like you said. But before that, and before that, we do a single leg vertical jump that's not off of a deficit. It's not off of a surface, because it's just almost as a progression. But yeah, and then the single leg hop for distance and this single leg triple hop. I don't use the 6 meter timed hop test. I have before, and just kind of giving background on where I'm coming from this, because you're right now getting a ton more experience with, I think, direct post-op, and I'm sure there's people listening in right now that are getting a lot more than me, but it's been about 4 years since I was getting post-ops, or more than that, before I moved to California, when I was working in a more traditional orthopedic clinic, where I was getting post-ops coming in directly, and I was seeing them through the entirety of their plan of care. But now I'm seeing people 6 months or later. sometimes even further out. So I'm still using the hop tests, but they're pretty high functioning. And so that's why I can kind of start with something like a depth drop or a depth jump, because we've got time, away from that. But yeah, 6 meter for single leg for distance, single leg triple hop, and then a couple of those vertical constructs. So that's where I'm at too. So I guess I'm kind of like that natural evolution.
Yeah, I think as I've started to learn more and more and just kind of recognize some of the issues that they pointed out in this paper, I've been utilizing them, or not utilizing them less, but putting much less kind of stake in the outcomes or the performance on the hop tests, just because for some of the limitations that they mentioned in here, where, are we really, how do we really gauge that we're getting a max effort on something like a hop test, different compensatory strategies and things like that. So I think I've gone away. It's still something that I think can be valuable and provide insight into just general progression throughout the plan of care, but I'm placing less importance on them now, given some of the things that are highlighted in this piece.
2 questions for you. Do you do how often do you test these? And do you do all of them every time you test them?
So one of the benefits with working very interdisciplinary is we've actually started to we're using epic values as much as we can now. So if someone comes in, let's say they're meeting with the ortho, they're planning to have reconstruction done, kind of utilizing even this paper and some of the others, kind of looking at, do we need to perform all 4 tests? What we'll do is they meet with the ortho. Okay, come over to the clinic real quick. Let's run you through single leg vertical. Let's run you through single leg horizontal for distance, triple hop for distance, and then a depth jump on the non-involved. And then we'll use that preoperatively to give us a baseline for what we're kind of shooting for. And then I would say that probably around, like, depending on where the person is at progression wise, probably 5 or 6 months or so, start to really look at it. And then every 4 weeks, we'll do them along with like isokinetic or isometric testing as well.
Okay. So 6 months, so 6 months is about when you really start to look to gather the data.
Yeah, just to kind of get a general gauge. I mean, you could do it beforehand, but I'd say around like 5 or 6 months, they're through a running progression by that point. Usually, we're starting to introduce some more, stretch shortening cycle type stuff. So
that was when I was seeing people from the beginning. 4 months was generally when we would clear people to run. Like sometimes we'd clear them at 12 weeks, but 16 weeks was probably more on the average. And then that's also the time that we started to gather data on some of these hop tests. But like the paper mentions the learning effect. And you're not going to think about anything that's supposed to be maximal effort. You're not going to get a true maximal effort. They're going to be apprehensive, especially in the beginning. So we almost use those 2 months of like 4 months to 6 months. We still gathered the data, but didn't put too much stock in it, because you would just see those numbers climb because it was like beginner gains. And then from 6 months on, then you wouldn't see such a steep increase, but it would still be steady. But we'd say that's probably more of like an accurate gauge of like their improvement. Like we're trying to get through that repeated bout effect and that learning curve in the beginning. Now the pre-op testing, because I'm jumping ahead on all my notes here, but that's good. Like I have not done that. And I have a question about that, because it makes so much sense just on paper, because they said one of the issues with comparing symmetry to the contralateral side is that, okay, let's say you got injured, you have surgery, you tear your ACL, you have surgery within 6 weeks or whatever, but you're still not like training that hard. So you're detraining through that period. And then there's 8 to 12 weeks after surgery where you're like, so that's months now that the contralateral limb has not been trained. Now you may test strength on the contralateral limb like ASAP after surgery, but as far as these hops, so that's a long time for your whole body to become detrained. And so now you're trying to get your involved leg to be compared to your contralateral leg and create symmetry. But now your contralateral leg is deconditioned and out of shape too. So you've just brought down the ceiling. So you might have symmetry, but it's a very low ceiling and it's lower than it needs to be to just sustain the forces in the environment. Now, the hop testing pre-op makes so much sense now because you've minimized the time that the contralateral leg can detrain. So you test that leg and then you use that as a reference standard. But my question is, like, during single leg testing, they have a torn ACL on their other leg and they hop on their good leg. Is there not like I'm just trying to think about doing that, having a torn ACL. Is there not a little bit of an e-brake or like fear of, well, what if I lose my balance and have to like put my other leg down? How does that work logistically?
Well, I mean, I'm sure it's definitely there, but I think the pros, outweigh the cons. I still think if we're looking purely from just like a performance aspect, as how much horizontal displacement can you produce? I still think it's a better gauge overall, even though there might be some sort of subconscious e-brake or restriction happening. I mean, you have to remember, like, if we're not talking about going back to like level one pivoting sports, I mean, you can operate pretty well on
Right.
on an ACL deficient knee. So is that at play or is that present? Probably, but I still think it's a better baseline number for us or a better goal to shoot for, even given there may be some sort of subconscious guarding or decreased effort happening.
But that's okay. But that's not been like a something that they report to you, like they're worried about, what if I lose, they ask you like, what if I lose my balance and have to put my other leg down?
Yeah, I mean, most of the time I haven't really run into that issue. I suppose
Okay.
that it could be, but we like to see people pre-op anyways, just to try and get some load through the quad anyways, restore range of motion.
Yeah.
Usually like, try and see them 2-3 weeks before surgery if we can.
So, okay. Because that consistently, when I worked in the insurance model, that we would do that too. We didn't test hops. We would test their quad strength in the contralateral, but that's new. I mean, it makes perfect sense. I'm just want to get my head around the logistics of that. And Paul in the chat says he's spent a lot of time getting pre-op data and finds it helpful as well. So, and the evidence is speaking to that too. So if at all possible, something that you guys can do. And if you're seeing teams, if you have the opportunity to be training different teams, or you have some type of relationship with teams, you could get pre-injury data too, preemptively, assuming that some of them are going to get hurt through the season. Maybe you run the teams through some hop testing while they're healthy, and then you've got good data as their baseline to, if they were to get hurt down the line, that's something you compare to too. Qualified. So Daniel asks, will you guys do closed kinetic chain strength testing, for example, single leg squat or retro step down for height, or quad or hamstring dynamometry to qualify them to begin hopping and or hop testing? So do you have some type of cutoff there, like an 80% quad index before you let them hop?
From a strength, so if we kind of go on this through like a criterion-based sort of schedule, let's use running as like a benchmark, right? So if we say that I want to see someone kind of go through like a jog walk program prior to start to look at hop testing, generally for that, I'd want to see like around like 70% quad index probably before we start running, like a quiet knee, something that's, that they're not presenting with positive sweep test or, range of motion is normalized. So I would say if they're hitting at least 70 around, like if for return to run, and we say we're another month out or so. So I would say probably the earliest that I would want to start to implement that would be like at least a 70% quad index. But I think that's probably a range as well. I don't necessarily have hard and fast data. I see it more as, okay, you hit 70, range of motion looks pretty normalized, knees not constantly swelling up, or we've gone through a return to running program. Now we can start to play around with some hopping or jumping progressions. So I would say maybe that's more like my gauge in terms of like limb symmetry. I don't necessarily say that you need to hit this before we start to implement hops.
Terry asks a good question. Do you think testing too early may bias clinicians toward trying to get the patient to pass the test? Plays into the learning curve. Yeah, I mean, I think that works both ways. I think the more often you test, I mean, the athletes are smart, whether they do it consciously or not. And the paper even touches on this. If I remember correctly, after reading, some of the athletes, they were some of the symmetrical athletes, their jumps were not as far, so their absolute numbers were not as good, but they were symmetrical. So whether these athletes are learning consciously or subconsciously that symmetry is kind of what we're looking for, they can figure that out over time. And I would suppose that the more they're exposed to the test, the more they figure out what you're looking for and what they need to pass. But at the same time, trends and data, the signal starts to come out the more data points that you have. So my thought is the more reliable testing, the more repeatable testing data points you can get over the course of care, the better. I think that outweighs is doing it less frequently, so they kind of forget what they're doing and forget what you're looking for. But then now you might be always dealing with the learning curve because it's too infrequent, and now they're like getting used to the test again, and you never get that full output. I can see it working both ways though.
Yeah, I see that. I think being mindful of just magnitude and direction of asymmetry is probably the biggest thing to kind of guide this. So like, are you trending in the right direction? And in some cases, if you take like, isokinetic strength testing, you're basically testing them to get as good as possible at the test. And then they're still having difficulty with it too. So I think as long as you're not using it as a standalone, I'm not necessarily too concerned about that.
I think the big thing here that I always have to tell myself is, to quote Eric Mera, who we just had on a podcast. We'll release his podcast this weekend. I'm excited about that. But he says the test tests what the test tests. And hop tests test your ability to hop. They don't, it's a quad index tests your ability to create torque. So, that doesn't necessarily mean that they're going to take that strength and then use it in a strategy that you think is optimal. That's the limitation of testing. A test is you're designing the environment, you're constraining the environment to hone in on a particular aspect. And that's one of the issues with hop testing, is that it's not as constrained. And there's a lot of things that the athlete can do to pass your criteria that you can't necessarily see or measure, that then doesn't necessarily transfer. So they talk about like the movement quality aspect. And I pulled I don't even know if they reference them, but I pulled a couple studies showing that an athlete can pass your 90% criteria for hop testing while using strategies that don't actually load the knee. And so the test is testing their ability to hop, but the strategy that they're using may not actually show that they can load that knee and absorb load through the system that you want. So that's where you want to look at strength testing. They can pass hop tests with a quad index that's very low, with low quad strength. So it comes down to there's no one construct that you want to be looking at. We talk about a battery of tests.
Yeah, 100%. I mean, that's the problem with like the arbitrary cutoffs, right? Because it doesn't really account for the kinematics, especially if we're talking about like the hop test right there. I think that's what makes this very difficult, is the closest thing we have maybe to like a best predictor is probably torque production or just general isokinetic strength testing at this point. But I think, again, you need to take multiple elements and assess multiple performance indicators or use multiple KPIs to kind of gauge where that person's at. And just one of the limitations that comes with something like the hop test is the lack of accountability for how they're performing the movement or the kinematic variables of it, which they touch on nicely in this paper.
David he asks in the chat. So guys, remember too, if you have a question about that you want us to touch on, use the Q&A box. But David asks a good one. He says, can you speak more about that non-knee loading hip strategy? How do we identify when that is happening? Well, I mean, it's an eyeball thing. It's 30 degrees or more of knee flexion. So if we say that a lot of ACLs happen with 30 degrees of less of knee flexion, so a pretty straight knee landing on one leg, we're looking for the athlete to bend past that threshold and to be able to absorb that force. So what you'll see is, Eric Mara's got some great blogs about this as well, but what you'll see is the athlete will land with a relatively straight knee and forward trunk flexion. And what that does is it shifts all the load back into their hip, which is a viable strategy to get the job done for that particular task. If the task is just jump as far as you can, or jump as fast as you can, or something like that, then, it's just distributing load. But the thought is they're doing that either because they haven't relearned how to absorb load through that knee, or they don't have that quality. They don't have the ability to resist the external torque that's required to offset the ground reaction force. They don't have the internal torque capability of that extensor mechanism. And so what they do is they lock a knee and they shift all of that load back into their hip. And what we want to see is a knee that can bend and that can flex and absorb that load. And I pulled a couple papers. There's a title for one, and I can send you the full papers on here, but there's a few pieces. I just put those into the chat. But there's a few pieces that show how one can pass the hop test with a myriad of strategies. And so now, to your question, you might have 5 different clinicians looking at a person, and one saying, oh, that's a hip strategy, big time. And the other saying, well, I don't know, his knee's bending. And the other 2 or 3, so that's where all of this stuff is still very subjective. It's easy to conceptualize knee strategy, dichotomize into hip strategy, but like in real life, it's very fluid, and there's a lot of room for interpretation there. But as in general, that's kind of what we're talking about when we differentiate those things. Let's see. And then Paul had a question here. And Kevin, maybe you can speak on this as far as clustering these tests, but he asks, do you believe any of these, even in cluster, are predictive of re-injury?
As far as I know, no. I think if you actually utilize the hop test, it actually decreases the predictability, from what I understand, based off some papers of predicting re-injury. There's they actually reference that in here somewhere, but the only thing that was shown a strong association with ACL re-injury was isokinetic strength.
And some of these tests are showing some redundancy as well. So they showed it was like the triple hop for distance and the single leg hop for distance. There's a high correlation there of those 2 tests in regards to their outcomes, in regards to the measurement. So what that means is those 2 tests are potentially measuring the same thing. So you might read that and think, oh, well, that's good. These tests are correlated, or that means they're repeatable or valid. But that's not necessarily what they're saying. They're saying, well, if you just did one of those 2 tests, you'd probably be getting what you need out of that information too. And so that's what they talk about with, should we be testing all 4? And I did see some discrepancy. They talked about the single leg test, the single leg hop for distance, and the crossover hop showing low correlation, meaning potentially those 2 tests are measuring 2 different things. So potentially you might want to have those 2 tests in there. And what are those things that they're measuring? Yeah, these are the questions. Well, they're measuring what they measure. The crossover hop is measuring the athlete's ability to kind of control, medial direction over a 15 centimeter deviation.
Yeah, I mean, I picked up on that too, and it was actually interesting. And this is where we kind of get back to where we're talking about asymmetry is going to be task and quality specific, right? There was I can't remember what paragraph it was, but they were talking about, it was essentially an example of someone's reaches normative values or shows good LSI and like a single hop for distance. and maybe they're speculating here. Okay, they have good torque production, they have good strength, but maybe they're scoring lower in like the triple hop for distance. So is this maybe an indication where this person lacks the ability to absorb and produce force? So maybe their reactive strength is kind of lagging. Can we maybe utilize or gauge how someone's performing on like a triple hop for distance versus a single hop to maybe become more accurate or precise in our loading prescriptions based off of how they're performing across these tests, if we assume that they are in fact testing different constructs? And I think that's one of the real things that I thought was really valuable, just to kind of like the narrative and discussion around this paper, is how can we, okay, we're saying that hop testing is not great as a standalone, but can we maybe shift the way we look at them in terms of using them as information to guide specific programming considerations, or honing in on areas where, what biomotor abilities do they lack? And I think that's something where I think they still have a lot of value.
Jared Boyd and Jennifer have, I think, maybe similar questions. I'll do Jennifer's first, because I think it's a little bit more straightforward. Do you cue them to perform qualitatively the way that you want? So for the vertical jump, if let's say you're seeing some valgus, or for the horizontal jump tests and you're seeing some hip strategy or something like that, are you cueing them out of those things? Are you saying, this is the task, go?
I really don't, because I just kind of want to see what strategy they're utilizing. And I feel like I don't want to bias them any one direction. So first time through, I'll just kind of explain it, here it is, just single leg, jump as high as you can, or, spend as little time as possible on the ground, and then just kind of let them have at it and see how they kind of organize around the task.
Because that flows into, I think, what maybe Jared is asking. And he says that, would you say there's still merit to assessing the qualitative output of the hop tests, meaning being cognizant of the strategies that they're using to achieve symmetrical quantitative outputs? Many athletes may employ a hip bias loading and landing strategy as opposed to quad. Maybe this is not innately wrong, but provides more information regarding his or her psychological readiness or load tolerance aversion. I think sounds spot on to me. And I think, Jared, you make a good point. It's not right or wrong. And like, this is where the clinician, you determine what you feel is going to translate the best, and what's going to create the greatest likelihood of success and reduce risk as best you can. And it's not that a hip strategy is right or wrong, because I'll tell you right now, planting a locked knee into the ground is a real high output performance strategy. Like locking that sucker and just jam. Like, I want you to go, everybody should go watch javelin throws after this meeting. And I want you to watch the last step of a javelin thrower as they plant. Their technique is a locked knee, and it looks like they just jam their hip back into the socket. Like, I have thrower friends, a couple of the weightlifting coaches at the gym were collegiate throwers, and they're telling me, like, yeah, you want to lock that knee as hard as possible. Like that plant leg, that hip feels like at various points of the season, because they're hammering it so hard. Because what it does is it creates all that ground reaction force, and it transfers it all to the implement. They're basically trying to lock down the system. So we're not saying these strategies are good or bad, but it's when you don't have another option. It's when on the field, if you don't have another option for that knee other than to lock it straight. And so if we subscribe to a locked knee is a potential mechanism, landing on a locked knee is a potential mechanism for ACL injury, the more exposure that you put into that strategy over and over and over and over, just from exposure alone, could be increasing your likelihood that one of those exposures could lead to something. But if you have the ability to bend your knee and absorb that load, it just gives you more variability. So that's kind of what we're talking about, is like providing the athlete with movement variability, and hopefully they choose the strategy that's most viable. Sometimes that strategy is to lock that sucker down if performance is the goal.
Yeah, I think we have to kind of remember context here too, though. So there's a big difference between like movement nihilism and like being neurotic about movement, right? But I think in the context, if we're talking about someone, this is someone that we're considering, okay, they've already torn their ACL. So we know that this is a mechanism that they maybe didn't have the availability or the option to get out of, or it was already a compromising position for them. I think it's a different question when we're talking about someone, if we're trying to reduce risk or, you know, quote unquote, prevent injury. I think that's a different conversation. In terms of someone that's post-op continuing to kind of utilize that strategy, I think that's when we're probably more likely to intervene. I don't know that I would necessarily do anything to someone that has not had an ACL reconstruction that is kind of utilizing that, because like you said, in many cases, it's a performance solution that they've come up with and likely become very good at utilizing to complete the goal task.
But at some point, even the person who had ACL reconstruction is going to utilize strategies that then maximize performance. But to your point, in a rehab setting, like we want to give them more options. It shouldn't be their only option. And I think to Jared's point, if you're seeing that consistently as their only option, locked knee, put all of that force into the hip, it may clue you in on they are either not confident or they don't have the biomotor capability at this point to create the torque necessary to absorb that load with a bent knee. Paul, so let's see here. We've got a bunch of questions. So Ari and Paul kind of talk about force plate data. So I don't have a force plate. Paul says that they've moved away from isokinetic testing because of poor validity for return to sport. The strength is good, but the variability of sport is hard to test. Paul, is that when you say isokinetic testing is poor validity for return to sport, is that more of something that you're seeing from a clinical experience over time? And if so, you can throw that out there. You know, we talked about, I can't remember which meeting it was, the quad, the test with the test. So if you test quad strength in an isolated way, that's what you're testing for. But that's, in my view, and I feel like the body of evidence would support this, is that's kind of a baseline. You should check that box off first. That doesn't mean that they're going to use it. And maybe that's the point that you're getting at. But they at least have that. They at least have an extensor mechanism that can withstand load. And there's no better way to test for that very baseline biomotor capability than an isolated open kinetic chain test. I don't have an isokinetic dynamometer. I use a pull dynamometer, and we just do isometric. So I don't test isokinetically because I don't have that, but I test isometrically, and our goal is to start ticking that box off first, because it's part of the beginning of the conversation that we had, that somebody can pass hop tests and have a quad index that's much lower than their limb symmetry index of their hop testing. And so I'm using open kinetic chain quad testing to try to bridge that gap. And it gives me at least that snapshot of what's their underlying capability in that regard. So we still use it. A couple of you guys are asking about force plates. I don't have a force plate, but I'll tell you also that Susan Sigward had a paper looking at athletes from 3 to 5 months post ACL who were doing squats, who visually look symmetrical, but are utilizing strategies that offload the quad. And I can put that paper up here too. But essentially, it's very, very hard. And a force plate can kind of pick up on the subtle weight shifts, but essentially the athlete can shift kind of into their forefoot. They can do really creative things to not load their knee.
And I will say, just to kind of build off of Paul's point right there. So I actually, when I was out at USC this fall, I talked to Susan Sigward about that. And I asked her, was that in the presence of, normalized quad torque? And it actually was. So they were still finding ways to offload that side, even though put them on an isokinetic machine, and their force production was, passing standards or relatively good. So it was almost like an ingrained learned mechanism that was still present, even though we had reestablished the ability to produce torque and absorb force, produce force through the extensor mechanism. So there's probably something there to that. I still think, like you said, like low hanging fruit, let's make sure that we're hitting peak torque and things like that. So I still think it's definitely something that I will continue to utilize and I think should be.
But the big point there was you asked her and she hadn't, but they tested it still.
Yes.
It wasn't, you didn't ask her and then she said, well, we didn't test that. And because then you don't know.
Because it surprised me, because like I was like, oh, like I'm gonna get her with this gotcha question, and she's like, oh no, they had established, they had normalized on their quad production or torque production on the quad. So
that's surprising me, because I thought all the participants in that study were like 3 to 5 months, like pretty early.
I think there's another paper. Isn't there one that was like 2 years out?
Oh, that's not the one that I'm talking. Okay, so that would make sense then. I'm talking about one where they look at it 3 to 5 months out. I believe. I'll pull that one up though. So we got other good questions here too. I don't want to get too off base, but great questions, Paul. Do you recommend, so for clinics that do not have the equipment for isokinetic testing, what do you recommend as a supplement to best match other than manual muscle tests? Well, not manual muscle tests. Jad, I'd recommend getting a crane scale. So you can get a $60 to $100 crane scale on Amazon, and it's a pull dynamometer that you can hook up to a chain, and you can have somebody do a seated isometric knee extension for max torque, and you can get peak torque that way. So that would be my recommendation. I have a dynamometer that runs about $800. It's a Mark 10, but a crane scale will give you that, and I would say that's a minimum. There you go. Manual muscle testing is not good enough. If we want somebody to be able to create a degree of torque that matches their body weight. Like, you're not going to be able to hold that. They're going to win. So you're not going to be able to get a peak if you just do a manual muscle test, if you do it right. So I would recommend a cheap crane scale to get some type of peak torque value. Brian asks, so by the way, we're probably getting away from hop testing, but fuck it. Brian asks, at the end of the day, what's the difference between a KPI that you find that works versus a quote unquote studied test, so long as it's repeatable, reliable, and valid and can measure actual change improvement? Well, I mean, that's a good question. So you can make up your own KPIs. It's the reliability and the valid part. Who determined reliability and valid? So at least the hop testing, it has controlled studies behind it to show reliability. So if you pick your own tests, you can do your own reliability studies. Validity is a little tougher, because what are you comparing it to as a reference standard? So those terms are generally, we're saving those for data that has been peer reviewed and kind of established. But ultimately, if you have a repeatable test, that's probably like the box to tick off first. Can I repeat the way that I administer the test? If that answer is yes, okay, cool, and we can move on. But yeah, I mean, I think you guys, after reading this paper, are probably realizing that there is no one battery of tests that's the gold standard for return to sport, and especially when it comes to hop testing. Ivan asks, what do you think about using video fixation and other methods of motion analysis? Could they be more accurate for decision making? Do you use them in your practice? I use the My Jump app almost exclusively. We use the My Jump for the any test that, like, they mentioned the 6 meter time test, which I actually don't use, but they measured they mentioned the reliability of that test is the worst of the 4, because you're looking at a bunch of different things. You have to look at when the heel comes off. You have to look at when they cross the finish line. The My Jump app, it's $10. It might be $2 now, because we're running a sale, but it allows you to slow-mo and to get frame by frame of when an athlete lands, when they take off, and when they land. And so that's the app I use for all of our vertical jump testing. And anytime I'm really trying to determine, really pinpoint moments in time. And it's really, really helped us to be a little bit more reliable with those things. We don't use wearables, and I don't have force plates, so I'm not getting into too much of the weeds there. Kevin, what do you guys use for motion analysis? Do you have anything like that?
Yeah, there's so I don't have access to like a motion capture, like a motion analysis, like full lab. But we do have like a single force plate, and then I've used the My Jump app as well, or things like Coach's Eye in terms of like
Yeah.
things that are a little bit more, um, I guess, practical. So I think those are probably your best bet if we're trying to utilize what we can, in terms of for those that don't have access to some of like the higher end sports science side of stuff.
Yeah. So Coach's Eye works too. Uh, Jennifer asks, would you say that you have varying expectations of limb symmetry success percentages depending on the activity that the individual is wanting to return to and who the individual is? For example, a young athlete wanting to return to high level rugby, you need the limb symmetry to be a higher percentage than an older individual who goes for a three times weekly run. I mean, yeah, it's just, it's informed consent, right? The problem is those people who go on a 3 times weekly run may also go on a ski trip, or may also play like pickup whatever every 3 weeks or something like that. It's just a conversation to be had. Like, we want to get you as strong as possible, and here's a general cutoff that we want our higher level people to reach, and we're going to strive for that. But for you, it may not be necessary for most of the activities that you do. Boom. And Kevin mentioned that if somebody has a 70% quad index, we can probably just start running. We can probably start doing some things, so generally to your question, yeah, the answer is there's discretion there based on their goals and who we're talking about. But the process, doesn't necessarily change. It's just kind of informed consent of here you are, here are the risks. If you're just literally just going to go on a run 3 times weekly, then yeah, the ceiling's a lot, or the floor is higher. The barrier is not as high to entry there. So there is discretion. You have any thoughts on that?
No, I think I would probably echo similar things. I think this is where if you have, I mean, you can find normative data for pretty much anything out there. So I think that's another thing to just like to consider. Um, but I mean, you'll test some people and, non-involved side will have, peak torque of 1.5 Newton meters per kilogram. So I think if we're starting with like something that is that low, I would still try to encourage, maximizing limb symmetry as much as possible. So I think taking into consideration like absolute force production is something to consider as well. I mean, it's a different story if somebody's non-involved side is 5, 6 Newton meters per kilogram and their involved side is, 1 or 2. I think I would be more concerned with a large asymmetry of that degree versus someone that is overall just not producing much as force, period.
Well, and a lot of those studies on relative torque were done with elderly masters populations, and they were still up in the 3
Yeah, I mean, I
kilograms
think
per Newton meter.
3.0 like I is that's like everyday person walking around is kind of like, I forget the lead author on that study, but I mean, yeah, it was like general population, like 3.0 Newton meters per kilogram. So I think it's something that I think you should probably utilize in terms of a goal that you're shooting for.
Max asks, do you guys implement a mid-thigh pull in return to sport decision to assess lower extremity strength in addition to quad strength? For my ACLs, again, I'm seeing people who have already been through a course of care in general. And a lot of them are in the barbell sport realm or training with barbell sports. We do, but it doesn't necessarily inform my decision from the knees perspective. It's more of just like general system strength, because there's a big difference between what an isometric mid-thigh pull is testing and what a very constrained quad test is, because there's a lot of, the isometric mid-thigh pull is using a lot of things and it's a different position. We're playing around with the unilateral isometric mid-thigh pull. We're also playing around with a unilateral partial squat. So they're in like a quarter squat position and they're hooked up to a pull dynamometer, and they've kind of anchored. So they're anchored to the ground and they've got one hand that's just balancing against the wall. And then they just push with one leg as hard as they possibly can, playing around with that too. But I mean, looking at symmetry in the same way that I would for these tests, but those things don't have any other reliability or validity data, or not as much behind them. Some of that's unilateral testing is starting to come out a lot more, especially with the groups from the UK, which is why we kind of started. But I don't see any reason why not. But I may be testing something that's not terribly relevant. Like if it's a soccer player and they can put 400 pounds into an isometric mid-thigh pull, what does that tell you? And they're offloading one side or the other. It's hard to see unless you're standing on a plate. So kind of just depends on what you're trying to get out of the test. Paul asks, how does time, i.e. neuroplasticity, play into testing and return to sport decisions? So do you guys look at that? Are you looking at 9 months, like trying to get to that point? Or if they're objectively meeting all of your return to sport battery at 7 months, 6 months, are you pushing that? Are you looking to say, okay, that we can start to talk about it? Or do you use that time construct as a cutoff as well?
I mean, I think it's going to be situational specific, obviously, but in my mind, just kind of looking at some of the data where we've seen that athletes that have power deficits and even athletes without strength deficits, there's a paper, it was one of the references in here, and I think it was a Paterno study or a Hewitt study. It was in the AJSM. Both groups were at high risk of re-injury. And I think based off of everything that we've seen, where we're getting as much as like a 50% reduction in re-injury rate for every month delayed up to 9 months, I don't see any reason outside of very special circumstances that I would ever clear anybody to go back before 9 months. And that's the nice thing about working with there's a couple of surgeons here that they say like it is going to be a 9 or 10 month process period. And that's very nice because when they come to you and now they already have that set down from the surgeon. So to me, I would be hard pressed to find a rationale to discharge someone back to sport outside of unique circumstances before 9 months.
Yeah, I don't know what the magic is about that number. That just happens to be where the data starts to just pile around, but there is something to time. The problem is when you use only time as a criteria and you don't look at any of these other measurements. And then if you only look at these and they've got limb symmetry indexes of that all pass your criteria, there's also something to just letting that tissue normalize for longer than 6 months, longer than 7 months. It seems that there's something going on there. We just don't know what it is. Now, again, it's your discretion. Like if you've got a collegiate athlete who's either got a scholarship on the line or a potential pro contract on the line, and this is their last chance to pursue that. If you've got a professional athlete, whether it's a contractor or something like that, there's always what about this situation? It's a matter of informed consent. You're still putting these, you still have these metrics in mind, and the athlete is informed of where you want to go, and is also informed of the risks if you don't get there. And so, so we just keep that in mind. Jared has a good comment here, and he says, I think tests allow you to develop a more efficacious intervention by limiting the level of noise at play within the individual system. It improves our stratification of key variables and where our efforts as clinicians need to go. So if we don't perform isolated quad testing, but perform an integrated test like jumping or hopping, we don't see what we think we should. How would we discern which variable to manipulate and how to intervene? So to that point, it's not either or, they're telling you different things. And then he goes on to say, perhaps looking at it as if you jump poorly and don't have sufficient quad strength, then you need quad strength. But just because you have quad strength doesn't mean you have the ability to integrate it within an emergent movement like jumping, thus warranting a different intervention as opposed to simply strengthening. Yeah. And I think we're all, Paul, and we're all kind of getting at the same thing, is that nothing as a standalone is going to get you to the finish line. But it's also constantly checking in. And I see people less frequently than I think a lot of people do. I see them about once every 4 weeks, but we do tests every time they come in. But I want those touch points, because one touch point every quarter, like, it's just not enough to me. That's what they were, a test is how you are on that particular day, which, hell, if you'd have come in 3 hours later after a nap and, a nice meal, maybe you test higher even on the same day, or or vice versa. So give, repeated exposures to testing, getting some data points, looking at where the signal's starting to come out at, and then knowing that each test as a standalone is limited, but as a big picture might clue you in with your decision making. And that's really all we're trying to do, is make the most informed decisions that we possibly can. And we're never going to have all the information.
Yeah, I mean, I couldn't agree more. In many ways, it's kind of a process of elimination in some ways. Just kind of like, well, is it this? Okay, they have this, so why are they not in it?
Yeah,
I think that's the challenging thing, is it's really just trying to build targeting, constraints of the individual, and then letting things play out as they may. But you have to test in order to figure out what you're working with, and then it's a process of elimination from there.
Stephen asked real quick, he says, do you have any videos of some of those tests you were playing around with, the dynamometer, the partial single leg squat? Yeah, I do. And you can shoot me an email and I can send you a video. And I didn't just make those up. So I'm pulling those tests from a lot of literature that's coming out from Chris Bishop and a lot of the crew over in the UK who are looking at asymmetry and unilateral work too. So, but I can send you a video, Steve. You just shoot me an email. Diana asks, the paper notes various reasons why the contralateral limb is not always a great comparison. And we kind of talked about that earlier. How would you set up pre-season hop testing? Well, kind of depends on if you're a coach or clinician and if you have relationships with the programs, but you could do like a weekend thing where you just spend an entire day running a bunch of athletes through these tests just to get, healthy athletes, just to get some baseline data. You could do this. You could do it each quarter. You could have them set up appointments to come into your clinic just as like wellness screens. And then you could just run people through hop tests at various, points in the off season, something like that, preseason. It kind of just depends on your situation. It sounds like if they've already been injured and you're looking at pre-op hop testing, Kevin, as you mentioned earlier, you guys just organize that as part of your treatment plan.
Yeah, just like go right across the hall and just be like, hey, so they're here pre-operatively, send them on over. It will be, 15 minutes or whatever, get the data, send them on their way.
Trying to see if, let's see what else I have here. Vertical jumps. What about any of the side hopping or like rotational hops you guys mess with?
I've not played around with much of the frontal plane stuff, I'll be honest, or kind of like the transitional hops, 180, 90 degrees. I think it's interesting. I haven't explored it much.
Well, and that's maybe the difference now between what you train and what you test. Because some of these tests, like you can make a test so hard that you're just nobody's going to pass it, and that's where you like lose out on your true negatives. Like or like the rotational test. Sometimes it just seems like we could test for anything, right? We can make anything a test. Like what Brian's point is, if we can try to repeat it, try to make it reliable. But we train in the frontal plane, and we do different rotational jumps. Jump facing one way, get to land facing the other way, um, and then jumping the other way, and quarter turns in the air and landing on one leg or something like that. But as far as making it a test, I haven't messed around with that stuff either. But go ahead.
Yeah, I mean, they kind of touch on this in the paper too. Like the sensitivity is not necessarily great for some of those from what they were kind of putting forward in the paper either. So again, I think it's one of those things where you have to kind of weigh your options a little bit. But I haven't dug into the literature enough on them to really feel strongly one way or another. I just haven't explored it too much, so I can't really say.
Brian asked, I tried to ask this earlier. I think this question is in similar vein. Do you think it's worth us as a profession then to advocate for people coming in for wellness screens to get the relevant info? Well, I think that's a question I think that's a bigger question, because that's what people are we talking about and what constitutes your wellness screen. So specifically when we were answering Diana's question, it was teams, and we were going to do testing for very specific things like hop testing, or maybe we get a quad index to a hamstring index. If we think about what we're preemptively trying to test for, specifically in ACL land, what are the tests that we're probably going to be using if they were to tear their ACL? Maybe we test those before they get hurt, so that if they are to get hurt, we now have a baseline to really compare off of. Now, to extrapolate that to now, should people come in for wellness screens, I think it's maybe too broad of a question to give a definitive yes, no on that. And we're not necessarily advocating that you even have the teams come in and do the hop testing. It's just if you want to, if your coaches, coaches and teams are looking to decrease injury risk or are looking to maximize or optimize their return to play, and you've had a lot of people come in post-op from these particular teams, and you want to see if they help with over time with your re-injury rates or your return to play, you implement something like that. But it's a very specific cohort with kind of a very specific aim. We would just have to talk about what you mean by wellness screens, I guess. I'm not one of those people that's vehemently against utilizing our services at various points of the year, looking at things. At the same time, we just have to define what we're talking about. Let's see here. I think that may be all I had on my end. Kevin, you got anything? What's that?
I would kind of just like to open it up for anyone that wants to contribute in the terms of, what does your sort of return to play testing battery look like? I think that's always good just to kind of see what other people are doing. And I'd appreciate, and welcome input from anyone, because we're not exactly doing too great out there in terms of re-injury rates, et cetera.
Paul, yeah. So I'd like to know, other than or hop testing, we can keep it on task there too, but any 5-10-5 testing or anything that complements these things. Do you guys go out onto the field, Kevin, and do various
late stage stuff? Yeah. We'll do like a 5-10-5, sometimes like a yo-yo, depending on the individual sport. And it has to be, somewhat representative of energy system demands, but
Yeah, Paul says he's using various runs based on the sport. Yeah, and still doesn't test all that the sport is. So that's, yeah, just so you guys know, there's no consensus on any ACL battery of tests. But I'd also say at least, have something, a lot of the evidence that'll say, well, having tests didn't show any, or wasn't predictive, doesn't help us in our decision making. A lot of times the heterogeneity of the batteries of tests are so different. And if we're not even utilizing the tests, we can't say that they don't matter. And that's, one of the big points is like, we should at least be looking at some stuff, and then we can kind of have a common ground to have a conversation. John has a question here. Do you think some of these tests are too easy for the athletes, such as the crossover hop test only being 15 centimeters wide? Do you think it would be beneficial of having the width of the lines on the subject's height? Yeah, maybe. It's one of the things where if you make it too wonky, it's less reliable, and it just becomes so hard that nobody passes it. But that could be something you train with. But yeah, it's an interesting question. You start to normalize some of these tests relative to the person instead of just having these very rigid guidelines that everybody gets 15 centimeters. Because if you're really tall or really short, that's a different challenge, right? Or 6 meters for 6 meter timed hop test. If you're really short or really tall, it's a different challenge.
yeah, I mean, I think, just to kind of echo what Paul's saying here in the chat is, nothing is going to replicate the sport. The best thing we can do is identify constraints of the person and, utilize clinic or gym time to target those constraints. But, if you want to replicate the sport, the best way to do it is a graded return to play and ultimately return to performance. So we can only target constraints of the individual, in my opinion. So I agree with what you're saying there, Paul.
Gino asks he says, to touch on Kevin's point, I do think our ability to rehab individuals post ACL is problematic due to basically everything we've talked about. And this was basically alluded to, but how much is ours or the athlete's fault? Dustin Grooms, who has some research suggesting an ACL tear is a failure of the central nervous system. As it was said, we can cross off every single box in terms of jump tests, quad strength, but at the end of the day, it seems like if that ACL is going to tear or re-tear, it's going to happen regardless. Just more of a general statement, doesn't have to be said out loud. Yeah, well, and I think Paul's getting at some of the neurological stuff too. So I'll be totally transparent that Dustin Groom's research flies over my head 99 times out of 100. And I've seen him speak a few times at CSM, and I'm like, oh my God. I mean, there's something to this, obviously. We're real far. And so we're pretty far from being able to kind of bottle it up and make it something that's practical in the clinic and like have a battery of neurological tests that tell us something. And so right now we've got things that are lower the barrier of entry to at least some. You guys are right. I mean, there's a reason that re-tear the way they are. If we do these batteries of tests and make all right decisions, that's why we can't prevent injury in the first. And we talk about the risk. So your point is well taken, and Paul's point is well taken. That testing is not the end all be all. Not going to tell us everything, and shit happens sometimes. But I think it's still, to Jared's point earlier, gives us something to jump off from, but we need to improve for sure. And the nervous system stuff is definitely a hole to go down. It's a deep one. We should get Dusty on the podcast. Yeah. So Terry kind of follows up with that, different reactions to commands while problem solving, change visual stimulus. You could go the Samuel Marcora route and start doing some brain fatigue, or, to what end, I don't know, but I'm sure there's something to this. I mean, like many meetings back, I think we talked about fatigue and its factor of these things, and like some of the
Yeah.
literature showing that fatigue doesn't matter, but like the quality of that.
I still got problems with that, man. We're not even inducing fatigue in those studies. Anyways.
Yeah. So I'm with you guys. I think there's something to that. So if you're looking for some of that mass training, neurological input, look into some of Dustin Groom's work, because he's spearheading a lot of that stuff. David says, one of my previous TAs at UD named Ryan Sarzicki is doing a lot of research on the neurological changes around ACL tears using transcranial stimulation to look at Hoffman reflexes on EMG or something like that. Over my head, since I'm not up to date on it, but something to look into. Jennifer says HS physio, so maybe you're in the UK or over there. So they have 15 minutes. So a battery of tests such as these provides a fountain from which the physio can maybe work with. Yeah. So there you go. I mean, so now you're under the constraints of your environment too, as the clinician. And so what's going to give me a snapshot? What's going to give some information to at least make some decisions? I get a peak torque measurement. I get a hop test measurement, or gives me some information to go off of. It's not optimal, it's sloptimal, it satisfies, to quote Scott Emerson, and it informs you to some degree. Also, it's got to go, but thanks for your contributions, Paul. We really appreciate it. And asks, fatigue not related to injury risk. So I think it is, but the evidence suggests maybe it's not. But to Kevin's point earlier, those fatiguing protocols we don't know how fatiguing they actually are. And a lot of them just look at like, oh, well, there's the ACL injury rates are not higher in the fourth quarter compared to the first quarter. But what does that tell you? What if the player just like they had a good rest? They sat out the entire third quarter, so they weren't fatigued going into the fourth quarter or whatever. I think we've got to look at like, we're not actually measuring if they are true fatigued. And then the question is, well, what is fatigue? And how are you measuring that? Is that psychological, physiological, some combination of two? So like that is just a lot there. I can't imagine there's nothing there.
Yeah.
Dave talks about now time. So he says, I know we are going towards more criteria-based, but still with time-based constructs in terms of tissue healing, ACL maturation. One study discussed waiting up to 2 years. I think they cited that in the paper too. Do we need biology to take course? Yeah, Dan, we talked about this a little bit, I think, earlier in the conversation. Kevin mentioned that they try to wait 9-month period as kind of that sweet spot. That's generally what's in my head as well. I think there is something to just letting Mother Nature do something to those tissues. Just letting the more time that needs becomes normal part of the system, the better. 2 years, the problem with 2 years is that a lot of athletes are going to miss out on things that would affect their future, or maybe 2 years and now you're just out of college, or 2 years and you miss out on that scholarship, you miss out on that contract. So there's a lot of limitations when it comes to that. In an ideal world, and also just the patient's buy-in, like, all right, this is going to be a 2-year process. You're not going to return your sport. We're going to hold you back, put you on a leash for 2 years. In an ideal world, if there are no like constraints as far as contract, scholarships, and the athlete is gung-ho on whatever you want for them, yeah, probably 2 years. But you're working within the real life constraints. But I do think, to your question, something to time.
Yeah, absolutely. I mean, the 2 years, I think Tim Hewitt's the one that's kind of spearheaded or first kind of floated that idea out there. So if you guys are interested in that, I'm sure you'll be able to. He's done tons of work in this area as well. So I think it's a piece of it, right? So we want to be criterion based, but we also have to be time based. So you have to respect both sides of it, like you said.
Terry says a tendon needs to start figuring out how to be a ligament. The thing is so common. Don't always appreciate how crazy tissue eventually learns how to be new tissue. Yeah, it's nuts. Not surprising it could take 2 years. And so I can't cite this off of my head. Isn't in the ligamentization phase, where that tendon is, or whatever graph that they're using is learning how to be an ACL, isn't it most vulnerable at like the 12 to 16 week mark, where it's actually degraded and then it starts to religamentize and go the other way? You're unmuted.
Let me pull this. I actually just had a PowerPoint with this on here looking at when the graph was most vulnerable. The tissue healing, it looks like almost like a check mark or like a Nike. A Nike swoosh. Let's see if I can find it here real quick.
Well, that's what David says. Yeah. Strongest initially, gets weaker, and then gets stronger again. While you're going, Jared says there is some literature that shows we self-regulate our output biomotor capacity during the perception of fatigue in order to limit threat to homeostasis. However, I'm still biased that the accumulation of fatigue may contribute to inability to maintain variability, which I equate to health. Yeah, he says, I don't know either, but I think you're right. I mean, we'll reduce this down to the hip versus knee strategy. Think about when you're tired, really tired, or like your legs are tired at the end of the game or end of the quarter or end of where you've had like a lot of back and forth. Say you're on the soccer field and you've had multiple sprints, repeated sprints, and now you're required to jump and land. When we talk about like energy efficiency, it's way easier than on a locked knee. Like if your legs are already burnt and now you have to bend and absorb, like that's just more energy. It's why, like, you think about, again, this is anecdotal, but like on the free throw line, if you've ever played basketball, when your legs are tired and you're on the free throw line, it's real hard to bend your knees and to get into that shot, use your legs for that shot. It's way easier to just stand there with locked legs and just try to use all your arms. And they talk about that. Like you always hear the announcers say, well, your legs are the first thing to go in your jump shot when you're tired. So I think that's, to Jared's point, your body starts to shrink.
Yeah, so here it is right here. So tissue necrosis and remodeling, loses strength, weakest at about 6 to 12 weeks. ACL graft appears like a ligament, but is at 50% tensile strength at about 30 weeks out.
Wow. And Brian he says that too. Yeah, 8 to 12 weeks is most vulnerable. So about that, like
we're running in some cases.
Exactly. That's what scares. When I first learned that, I was like, oh shit. Like it almost scared me too much. But like, okay, think about somebody that goes back after 6 months. What did you say? 30 weeks, right? So there's something to time. Biology doesn't move all that fast when it comes to this stuff. Not everybody's Adrian Peterson. 30. Kevin Tommaso asked, when it loses tensile strength, 30 weeks? Can you just repeat?
Yeah, so 16 weeks, collagen bundles start to appear. 26 weeks, we have evidence of cellular repair decreasing. The graft is at its weakest at roughly 6 to 12 weeks and about 50% strength at 30 weeks.
Sweet. There you go. Well, let's see. What's the reference for that?
Let me see here.
Laura and Steve want to know, and I did, and all of us.
Give me 1 second here.
If it's a blog, you can just tell the truth.
Oh, I'm not sure what the reference was. I pulled it off a slide here. I'll post that in the forum though.
Okay, pulled it off a slide. If anybody else has a reference, but it sounds like we were all kind of on the same page. Yeah, I've heard that too. Yeah, 12 weeks. So kind of one of those eye openers too. And who asked about, Daniel. So I always talk about the pendulum swinging. We talk about that a lot in these meetings. So from time to criterion based, how about they both matter? And so that data right there is kind of an indication that there's still something to time. Brian says he also pulled it off a slide with no reference. Well, listen, this is herd. This is the herd. So like all of us seem to be on the same page that we've either heard or it makes sense. And we've all kind of like that check mark. So wait till people saying the same thing for it to be false. It has to be true. We'll just put it right down. It's a validated theory. I think that's all on this. It's a good one though, guys. I mean, read it again. It'll give you some avenues to dig into a little bit more. Sometimes some of the uncertainty helps because if you're doing something along the lines of what it's talking about, then you're probably doing as much as you possibly can based on what we know. At least from these, when we're talking about these particular tests. So sometimes the uncertainty can take some pressure off, but just, start somewhere. You can look at all these tests. There's YouTube videos on these things galore. Steven says, first Clinical Athlete Journal Club, awesome discussion. Thanks, man. I'm glad you enjoyed it. So we've got a couple topics for the next meeting. So this topic literally won by one vote. We had like hundreds of votes, and the other one was non-op management of ACL. So that's in the hat too, but maybe we save that so we don't do 2 ACLs in a row. But somebody threw out motor learning in the forum as a potential topic. If you guys have other ideas, throw them out there. We're always willing. Daniel says, thanks so much. Yeah, thank you for coming. But otherwise, Kevin, are you still looking hard for that paper?
Yeah, I'll find it.
Okay. Are you afraid that you were just spouting a bunch of bullshit?
No, it's not bullshit. I know I try not to say anything without a reference, but
I mean, if it's ultimately it's my fault because I started throwing out the whole. Isn't this a thing that maybe I read, but I can't remember either?
It's fake news. It's fake news.
Kalani, I think he just put a paper, the ligamentization process in anterior cruciate ligament reconstruction. What happens to the human graft? A systematic review of the literature. And he says This is what was referenced in his musculoskeletal ACL lecture. Cool, thanks for that. So everybody in the chat. So that's one. And it's a systematic review. So maybe all of the papers that we're thinking in our head are part of that review, and then we can be happy. Yeah, Brian, you're good. Okay. I'll give people time to copy and paste that reference. But otherwise, you guys have a great rest of your day. We're going to release Eric Mara's podcast. It's actually part 1 of 2. It was the dinger. And that's very relevant to our conversation here because we're talking about the knee, talking quad, ACL, very, very relevant. Jared threw out some potential topics, motor learning, blocked versus random practice. I like that. I love dichotomies. Differential learning. That would be a good one too. Thanks, man. And thank you for participating. We definitely do your thoughts.
For sure.
So yeah, anytime you can join, we would love it. If you don't know, Jared was on the Clinical Athlete podcast as well. And it was a really good one. He also did a webinar for us and just money. But, all right.
All right, guys.
That's a wrap.
Quinn,
See you guys
thanks
next
as
time.
always.
Stay safe. All right. Bye.